Hey there, and welcome. I'm Anna Hartman, and this is Unreal Results, a podcast where I help you get better outcomes and gain the confidence that you can help anyone, even the most complex cases. Join me as I teach about the influence of the visceral organs and the nervous system on movement, pain, and injuries, all while shifting the paradigm of what whole body assessment and treatment really looks like. I'm glad you're here. Let's dive in. Hello. Welcome back to another episode of the Unreal Results podcast. Here we are, end of the day. I've been trying to sit down and do this all day, but I'm still in recovery mode from this weekend. I was up in Tacoma, Washington for the first LTAP Level 1 course of the 2025 season of the year. And so it went really well. I was cold. It snowed in Tacoma, which I hate the snow. If you're new here, maybe you don't know that, but everybody else probably knows that. But yeah, it was a really great course, great group of people. I feel like pretty much everybody was from around the Pacific Northwest area there. One from Canada, a couple from Idaho, one from Montana, a couple came in from Phoenix. But then other than that, everybody was local to Washington, Washington State or Oregon. There was another couple people from Bend, another couple from Eugene. So, super excited to be educating more and more practitioners and just getting this work out there. It's so needed, and it's so good, and it's so practical. I mean, I feel like everyone at one point came up to me during the class and just told me how much they were loving it. And I already have heard from a couple this week, letting me know that they're practicing it with their patients and getting great results. So I love to hear that. Leading up to the course, as maybe you know, I had the flu. So I've had a cough from the flu pretty much ever since. Usually when I have a cold, or the flu, the cough usually lingers for a month. COVID was like that too, and that's so frustrating. I don't know if it's because I had pretty bad asthma when I was a kid or what, but I really hate how that works. So trying to knock this out quicker. I might have to do some intense cardio. Sometimes that really helps, just the breathing hard. But anyways, because of all of that, I just am pulled to needing some extra rest. But I got a lot to do. So, and I got a busy couple of weeks coming up. So I'm just pushing through. One of the things when I was in Tacoma, I stayed at a hotel right on the water, right on the Puget Sound. Down across from Vashon Island. I was hoping to see some of the orca pods that are there in the Puget Sound, but I missed them. When I left Tacoma, they were probably 10 miles north of the hotel. There was a group of them. So I was oh, they're so close, but it's still so far. So maybe next time. Maybe next time I'm in Seattle, I'll see them again. But it was a great hotel. Just a great experience. So if you were there, thank you for being there. I appreciate you so much. And if you've been on the fence about joining, what are you waiting for? Come join our amazing group of professionals that just building this community to push the industry forward and change the paradigm. It's just so fun. So anyways, that was my week last week. the flu and teaching. And this week, I'm actually flying up to my hometown of Eureka, California. Flying up there. Gonna see my uncles. My aunt and my uncles. I haven't seen any of them. My uncle, who I'm staying with on Thursday, I haven't seen in like years. I'm pretty sure I haven't seen him since before the pandemic, which is wild to me. But I think the last time I was in Eureka was when my dad, like right before my dad passed away, and that was 2019. That's probably the last time I saw him. So I'm looking forward to seeing him. And then my aunt and I are driving to Sacramento so she can see my sister and my nieces. It's been a while since she's seen everyone. And the drive from Eureka to Sacramento is like 6 hours. You know, windy, coastal highways, Northern California, like rural 2-lane highways. And she doesn't feel super comfortable driving by herself anymore, so I volunteered to fly up there and drive her and then drive her back. And also, it's just, I'm looking forward to being in Eureka. I haven't seen Eureka, like I said, I haven't seen Eureka in a really long time. Got some like very like special food items that I'm looking forward to get and to bring some to my sister and bring some home. There's this restaurant in Trinidad, California called Larapin's, and they have these sauces that they sell. Larapin sauce, there's 2 of them. There's a Larapin's red barbecue sauce, which is so good. It's like this rich molasses-based barbecue sauce, and then there is the better of the 2, like the one that like I miss the most is this honey mustard dill sauce, and it's so good. And so whenever we go home, we try to stock up on that kind of thing, even though they do ship it. It's just, I don't know, it seems more fun when either somebody sends it to me or if I get it on my own. So looking for that. Actually, my sister just told me that Trader Joe's now has like a sweet honey mustard dill sauce. And she was looking at the ingredients and she's like, Anna, it's like the same thing. Which it would be completely wild if Trader Joe's ripped off Larapin's sauce. For 2 reasons. 1, because like it's so good. But then 2, because that makes me feel bad. Anyways, so looking forward to that. My favorite bagel shop of all time is in Eureka called Los Bagels. So I'm going to stop and get some bagels. I like to do a bagel with cream cheese and then carrots, shredded carrots, and Larapin sauce on it. It's so good. So I'm going to do that. And then I shouted this out on my Instagram the other day when I was making a steak, but there is this meat seasoning that was sold at the old Eureka Meat Company from the butchers there who were named Ted and Barney. It's called Ted and Barney's Meat Seasoning. Eureka Meat Company no longer exists, and I think either one or both of those butchers have passed away. Maybe. I know that, I mean, they definitely retired, but I think at least one of them passed away even. But their product, Ted and Barney's Meat Seasoning, still exists, and it's still amazing. So I would definitely pick some of that up because I'm almost out. And the funny thing about that meat seasoning is it's not even like some special mix of like herbs and spices or something. Like, it's so simple. It's salt, pepper, garlic powder, and chili powder. That's it. Like, when I use all those separate and put it on the meat, it's good, but somehow when I do it as Ted and Barney's Meat Seasoning, it's so much better. And it has to be in the ratios, and I wish I could know what ratios they used, or like in like the grain size. I don't know what makes it so much better, but it's so much better. So those are like the have to gets, and then there's some like jam I like from there, and then a candy shop was really good candy, like a C's candy, but like better, called Partrix candy. So I don't know if I'll make it to Partrix. My sister and I just had it over Christmas. But Los Bagels and Larapin sauce and Tannenbarty seasoning, definitely getting all those things. So would love to have some time to see some of my high school friends while I'm there, but I'm not sure I'm going to have time. We'll see. I might see if anybody wants to like meet me for drinks or something on Thursday night, but I don't know. But anyways, not looking forward to like the drive, but looking forward to the trip. So excuse my yawn. I told you I'm tired. Anyways, I asked recently, well, if you've been listening in the last few episodes, I've been talking all about the foot and ankle because I have a foot and ankle self-paced online course coming up. Having the flu last week, pushed it back again. But with that said, like, I feel like I was at a point with the podcast about the foot and ankle where I'm like, okay, I've talked about it enough. Like, let's move on. Maybe as I continue to finish that course, I might have some other topics about the foot and ankle that I want to share, but we'll hold off on that for now. I have some new ideas for some episodes. I did ask on Instagram for some ideas or requests, and so that's what this episode is actually going to be. One of my certified providers, actually, shout out Beth Dreyer, she has a patient right now who has a lot going on. One of the things that they have going on is they have a hemiparalysis of their diaphragm. And so she was asking about an episode related to that. And I was like, you know what? Let's talk about this. Solely for the reason of it is pretty rare, but I've had a couple patients with it. And because it's pretty rare, there's not a lot of information out there on like, what do you do? Like, where to start? Especially from a standpoint of like, I'm assuming that most manual therapy or movement practitioners are kind of like, where would I even start? Because like, can I even help? And is it worth doing? And or is this something that a doctor needs to address, and like what to do? So I wanted to share my insight around that. So yeah, without further ado, let's dive into that. So diaphragm paralysis, you can have unilateral or bilateral diaphragm paralysis. Obviously, bilateral is a little bit more of an emergency since your diaphragm is the main muscle to create respiration. Though you can technically have a paralyzed diaphragm and still breathe with your accessory muscles. But most of the time, if you have a bilateral paralysis, you might be on a ventilator or needing some sort of surgery to have like a pacemaker put in so you can have some function of the diaphragm. When you have unilateral like paralysis or hemiparalysis of the diaphragm, it's less of a emergency situation, and you don't necessarily have to get surgery. However, there are surgeries that you can do. Any of the surgeries that you can do or any of the solutions that you do happen to be based upon like what happened in order to create the paralysis. The paralysis can happen from infections. It can happen from like crush injuries to the phrenic nerve. So it can be an injury to the neck. It can be injury to the mediastinum. It can be injury to lower down in the thorax. Basically anywhere the phrenic nerve is, you could potentially injure it. Oftentimes it is a iatrogenic injury, meaning like an accident. It gets, the nerve gets nicked in a vascular surgery or a thoracic surgery, or a orthopedic surgery of the neck. And but it can also be injured in traumatic accidents, like I said, illness, infection, different medicines people take. These are all things that could cause it too. And then there's obviously diseases that it would be common in, like ALS, multiple dystrophy, I think is one, like just those kind of neurodegenerative type of illnesses. So I think it can also be affected in a like diabetic neuropathy scenario as well. So all possibilities. And obviously, if someone comes to you with this, you're helping them figure out, along with the doctors, like what happened. And that is sort of where my knowledge of it comes from, is because a man who was a friend of my old boss / colleague, Mark Versagen, he spontaneously, without incident, had a diaphragm paralysis, and no one could figure out how to help him, and also like what was going on. Like even the doctors were like really unsure, because he didn't have a traumatic accident. He didn't have any medical procedures where it would have gotten injured. And he had been sick, but it didn't necessarily exactly coincide with his illness. So they were a little bit stumped on what was happening in the first place. And so Mark basically told him, they're like, Mark said, if anybody can figure it out and help you, it's Anna. And so he referred him to me, and he came from out of town to see me. And I was like, wow, this is really challenging my guaranteeing results in 1 to 3 visits, because I was like, wow, I don't know. But just like I would approach any case, the most complex case or the least complex case, everybody, it's the same. I start with my general listening. I start with the locator test assessment protocol, the LTAP, because I want to actually not be distracted by the story. I don't want to be distracted by the fact that they have a paralyzed diaphragm. I want to evaluate their body in the most non-biased way, so the body can help direct me where to apply treatment to have the best chance of helping them out. And this is where the practice of like how it was so important that I had so much practicing letting the body's wisdom guide me. And the first time I saw him, his listening, his test took me to like liver, right lung, and that it was his right side that was paralyzed. And I mean, I did kind of my basic treatments on him, and I did a liver lift and liver visceral mobilization, and like I cupped around the area, and I did like a bronchial tube stretch, and I did a little work on the phrenic nerve at the area Debussy's point, which is the area down by the 10th rib, where the where the phrenic nerve sort of interacts with the diaphragm down there. And I was like, I don't know, like I don't even know what to expect with the treatment. And actually within that session, his pulse ox improved and his respiratory rate decreased, and because he was in like a hyperventilation state, his coloring of his face changed, definitely looked better. And then he reported to me afterwards, like driving back home, it was like the best his breathing had felt. And then that night he slept better than normal. And so I was like, whoa, that's really interesting. And then I saw him a couple more times, and it was similar treatment, similar direction from the LTAP. There was one day it like took me to his legs and we did some nerve glides, and that seemed to like, everything we did always seemed to like help a little bit. But it definitely it definitely encouraged him to keep moving and keep doing things to help. And my thought process too, so this is, I guess, what I want to share is not just this case, but kind of my thought process of how to approach something like this. So the first step is, where does the LTAP lead you? And the orthopedic tests around something like this are going to be, obviously, evaluating rib mobility and breathing pattern, evaluating trunk mobility, especially with a chest lift. So lifting our head and chest up requires the diaphragm to function optimally. That's actually, when we look at development of a baby, as a baby gains control of their head and neck, it's because the diaphragm starts to drop down in the chest. And so this is the same, my thought process with this, using this as an orthopedic test, and then also one of his exercises to work on was, when you have diaphragm paralysis, what happens is the diaphragm goes into a exhaled position, a shortened position, and it domes up and elevates in your chest. So that's actually how they can see on x-ray what's going on, is how high the diaphragm is in your chest. And so we use that as an orthopedic test and like a milestone to be aware of. So head and neck control via chest lift. And then the other treatment strategies were to address cervical mobility, cervical like neck fascia mobility, retroclavicular space or thoracic inlet mobility space treatment, and then also to facilitate the phrenic nerve through the phrenic nerve sensory pieces. And the phrenic nerve is a sensory nerve to the organs of the mediastinum, the organs of the thorax, and then the abdominal organs within the thorax as well. So the peritoneum around the liver, the stomach, the upper part of the peritoneum, basically. The parietal peritoneum. And so doing just general focused visceral mobility work in those areas was also a key part of his rehab plan. And after our second or third visit, every time he saw me, he did feel like it helped, though it wasn't like all of a sudden it wasn't paralyzed anymore. And my theory was too, like, if all we do is support all of his accessory breathing things, then like worst case scenario was we're helping him anyways. And at the same time, we were going into COVID, and we were like also very worried about him getting COVID. And so it was my goal to really show him as many tools and exercises that I could around breathing, thoracic mobility, like keeping health of the lung and the diaphragm function that he had on the left. So at one point he saw a doctor, and the doctor found that he had a sort of hidden infection between his liver and his diaphragm. And so the doctor put him on some antibiotics and some other sort of, maybe even like an antifungal or something like that, to knock that out, hoping that maybe that was what had created this paralysis, was an infection on the phrenic nerve. And at first, after that treatment, he did feel like he regained a little bit of his breath function. But then when he went back to get an x-ray, it really hadn't changed the position of his lung much. So he was a little bit defeated. And then he came and saw me again. And then that day, I was led from the LTAP in my general listening to the area of the phrenic nerve in his neck. And when I was setting him up for treatment in his neck and doing the actual neural manipulation to the phrenic nerve at the neck, I noticed that I would position him in a way and then do a certain treatment, and I would see his breathing reflexively turn on, and then I would take him back out of the position and it'd turn back off. And I was like, oh my gosh, I think you're having a positional thoracic outlet type of scenario on the phrenic nerve, like a positional entrapment of the phrenic nerve causing this. And I was very encouraged, and I called a doctor that I work with, Dr. Schaefer, and I was like, hey, have you ever heard of this? And he was like, no, I've never necessarily heard of it specifically to the phrenic nerve. He's like, but it would make sense that it's possible. And the hard thing is to diagnosis, especially when it's positional thoracic outlet like that. And he referred me to this doctor in Texas that works with baseball players specifically on positional thoracic outlet syndrome. And so we were working on getting that referral. And in the meantime, I decided to go to PubMed and do a search on compression of the phrenic nerve, at the thoracic inlet. And I was like, there's got to be something written on this, because the doctor said, knowing the anatomy, it's very possible. And as I said in my evaluation, I witnessed it. And so I came across this article it was a case report, and it was an article referring to a thing called Red Cross syndrome. And Red Cross syndrome is basically the transverse cervical artery, which is one of the branches of the arteries that come off of the, I believe it comes off of the carotid artery, the transverse cervical artery. It crosses over the phrenic nerve, and it can actually be a crush point or compression point of the phrenic nerve. And in at least these 3 cases that the doctor had written up, caused unilateral paralysis of the diaphragm. And I was like, oh my gosh, the location that the transverse cervical artery was at, when I looked it up, I was like, that's exactly where my hand was when I was working on the phrenic nerve. That's the spot. So I sent it to him, and I was like, I think this is what's going on with you. And he took it to a vascular surgeon in the Orange County area. And the vascular surgeon said, I've never heard of this. It doesn't exist. But I'd be willing to do an exploratory surgery to help you out, because this has been going on for so long and nobody knows. He's like, so I'm down with doing an exploratory vascular thoracic surgery, basically, to see. So the patient was like, I'm in. And so they did the surgery, and I get a text message from him later that day, and he was like, you were right. He's like, the doctor went in there and he found that I had double Red Cross syndrome, which was 2 arteries, both going transverse. So two transverse cervical arteries causing a compression on his phrenic nerve. And so they ablated those arteries and then stented the phrenic nerve right there, in the hopes that maintaining the space around it, it will sort of rebound and he will regain function. He had a noticeable change in function within the first, few weeks of surgery, but then and then it kind of like calmed down, and the vascular surgeon like assured him that it might take a little bit more time. And that we wouldn't really know how successful it was until about 6 months after surgery, because when a nerve has been compressed for that long, sometimes it doesn't regain its function. So, but either way, it was like so validating for me to be like, that is it. I like figured it out. And I figured it out it wasn't me. It was kind of me figuring out, but it was mostly me figuring out because the body directed me there. And so that was a really cool scenario. And then he from a rehab standpoint, he continued to focus on all those things that we've been doing, right? Keeping the liver happy, mobilizing the anterior upper organs of the peritoneum, doing breathing exercises, doing chest lift type stuff, doing like neck mobilities, things like that. So a limitation I had with this patient was that he didn't live where I lived, and so I didn't get to be super active in his rehab. He basically rehabbed on his own. And he had tried working with some other practitioners that did like STEM and things, and nothing really nothing helped. So then a couple years later, I got a phone call from a random guy who was referred to me from a physical therapist out in the New England area that had taken my mentorship and had heard this story about my patient with the hemiparalysis. And she referred him to me because she's like, this sounds exactly like the case that Anna had. So go talk to Anna. So this guy talked to me. And it did. It sounded exactly like it. Like just one day woke up and diaphragm didn't work anymore. Nobody could figure it out. This guy though was like very much like, both the patients were very much like, I'm figuring this out and I want to get better. They were both very motivated to improve. They're both like military backgrounds, like high level military backgrounds. And this is just like their mindset too, that just like push and work as hard as they need to and figure it out. And then so I put them in contact with each other. And then this guy just so happened to find a doctor on the East Coast that did reconstruction surgery for the phrenic nerve. The doctor on the East Coast takes like the sural nerve out of the lower leg and uses it as a graft and reconstructs the phrenic nerve from the root of the spinal cord down to the diaphragm, and which is just fascinating to me. And so he went ahead with that surgery, and I believe it was successful. I never really heard from that patient again, but he communicated with my old patient, and sure enough, after 6 months or more from the vascular surgery, he never really regained function of the diaphragm. And so he became a good candidate for this reconstruction too, and decided to go get a reconstruction using his sural nerve. And the interesting thing too is whenever I worked on this patient's neck, it was like his neck was really stiff, and I didn't really ever feel like I was making real gains in anything in his neck. And also the MRIs would never really show anything of significance in the cervical spine that would lead us to believe there was some sort of like stenosis causing a nerve impingement in that area. But when the doctor went in for this reconstruction, there was significant damage around the neural foramen of the cervical spine at the level of C4 too, which that tells me that this patient had like multiple areas of compression to the phrenic nerve causing this paralysis. So the Red Cross syndrome area, perhaps why his improvement after that was minimal, was because there was another area of compression going on. So like a double crush syndrome. And last I heard, about this patient. Last I touched base with him, I think he has been doing pretty good. I need this podcast episode. I'm like, I definitely need to see how he's doing. He said the recovery, last I heard, was like right after surgery, and he's like recovers slow but improving and like doing well. So I hope he's still continuing to do well, and I hope he has like full function of the diaphragm again. But it was like such an interesting case, and yeah, I just felt like when Beth asked me to talk about this, I was like, yeah, I guess I probably should share this on the podcast. I've talked about it before, but I present it in the mentorship because I show the pictures of this, the surgical pictures from when the doctor did the ablation of the artery. I don't have surgical pictures of the reconstruction. That was a different doctor, but it's just a great story in terms of really listening to the body, let the body guide you, and then understanding the anatomy. And when you understand the anatomy, you understand it opens up so many options of locations or areas for treatment, both from a manual therapy and a treatment standpoint, like a manual therapy and an exercise standpoint, as well as different areas to consider to like help figure out what doctor is going to help us diagnose it, right? Like all the different areas, all the different doctors, right? There was like an infectious disease piece of it. There was a peripheral nerve entrapment piece of it, which was a vascular piece. So it involved a vascular thoracic surgeon. And then there was an orthopedic and neurological piece at the neck. And then there was a neurological piece with the graft from the sural nerve to the neck. So it's like, wow, so many different opportunities. And I think in cases like these, so many patients give up. So many practitioners give up because they're like, just don't know what to do. And both of these patients were unique in the fact that they were not giving up. They were very motivated in their care, taking care of themselves. And then they were very motivated in finding practitioners to help them, both from a surgical and physician standpoint and a rehab professional standpoint. And that is a huge key characteristic of someone who has a successful outcome. I always tell people that, like, not every athlete is the right athlete for me to work with, because I know it takes an active participant in their care to sometimes really figure things out and to fully get the result that the person wants. And you can only want it so much for your patients as the clinician, because there's so much other stuff that goes into helping them out, and they have to want it too. So my like wrap up on that, besides like I talked about at the beginning, is like consider all the areas: the neck, the cervical fascia, the thoracic inlet, the thoracic cavity and mediastinum, the thoracic cavity in the parietal peritoneum. Like all of those spots are going to affect the phrenic nerve. The role the diaphragm plays in movement, not just from breathing, but from head and neck control and chest lift, upper thoracic flexion. So the understanding all of this, which I did an episode not too long ago, all about the diaphragm. So that podcast episode is a great resource, and I'll have Joe link that in the show notes too. But like understanding all of that paired with an assessment like the LTAP that's going to help direct you where to go and how to unravel things, in addition to this knowledge about all the possible reasons why someone could have this paralysis and what doctors are out there to potentially help it. Like, this creates a big picture. But at the end of the day, if the patient, the clinician, and the physician team are not willing to do all this work to figure out what it is, like, you can only do so much. But the so much is also important, because let's say worst case scenario, these patients didn't find that doctor to do the reconstruction, and we're left with a paralyzed diaphragm. The other options, right? There's a couple other surgical options for them. One surgical option that's common is a plication of the diaphragm, which basically takes the diaphragm and pins it down into a lower position to allow for space for more lung volume and not impede upon the space so the accessory muscles can work better. It's not ideal, but it is an option. And then there's also an option for a pacemaker of the phrenic nerve to create diaphragm function. The downside of that is if the nerve itself is affected, you put a pacemaker to it, but it's not going to actually fire the diaphragm. So that is limited as well. But also just knowing that these doctors exist, right? Like, so, and I'll make sure I have Joe link these doctors in the show notes too. Just if you ever find yourself in these positions, like, these are guys that like have seen it at least once and clearly think out of the box a little bit differently. So hopefully this was a helpful episode. I know it's like very niche, but also very interesting. So wow. Yeah, diaphragm paralysis. Doesn't sound fun. And hopefully this gives you a little bit more insight into be able to help your patients if it does come up. So thanks for being here. See you next time.